Bismillahirrahmanirrahim. Today we will discuss the topic of vaginal birth after cesarean section based upon the RCOG guideline. Okay, so first question is that what is recommended schedule of antenatal care for the pregnant woman with a previous cesarean delivery? Okay, about this I would like to say that implementation of vaginal birth after cesarean delivery versus elective repeat cesarean section checklist or clinical care pathway is recommended. Okay, so we make a specific checklist in UK about each and every problem. We have specific checklist, and whenever we go to the management of the patient, we just check our checklist whether we have fulfilled all the requirements or not. Okay, so checklist or clinical care pathways, there are specific pathways. Those are recommended to facilitate what we need to facilitate with these checklists: best practice in antenatal care, counseling, and shared decision making and documentation. Okay, so that is a very important thing. Now, which women are best suited to have planned VBAC? Okay, this is a very important point, that we cannot offer VBAC to each and every woman. Planned VBAC is appropriate for and may be offered to the majority of women with singleton pregnancy of cephalic presentation. Okay, so the pregnancy should be singleton. Okay, it cannot be offered to twin pregnancy except the second twin. Okay, and the presentation should be cephalic. Okay, so in the breech presentation, in transverse lie, in another malpresentation, we cannot offer VBAC. Okay, and it is offered at 37 weeks or beyond who have had a single previous lower segment cesarean section with or without the history of previous vaginal birth. So these are very important prerequisites. Okay, now what are the contraindications to VBAC? This is also very important questions. Okay, we cannot offer VBAC to the woman with a previous uterine rupture. Okay, those women who had previous rupture of the uterus, or those who had cesarean section with a classical scar, and those with having other absolute contraindication to vaginal birth that apply irrespective of the presence or absence of the scar, for example, major placenta previa. So these are the specific contraindications to the planned VBAC. Okay, now in women with complicated uterine scars, caution should be exercised and decision should be made on case-by-case basis by whom? By senior obstetricians with access to the detail of the previous surgery. Okay, now can women with the 2 or more prior cesarean sections be offered planned VBAC? Okay, so we have women who had 2 or more previous lower segment cesarean sections or whatever type of previous cesarean sections, but yes, they had 2 or more lower segment cesarean sections. So can we offer to those women? Okay, yes, it can be offered to those women with the 2 or more prior lower segment cesarean section after counseling by the senior obstetrician. Okay, so there should be a detailed discussion with the senior obstetrician, because the senior obstetrician will make sure that each and every pathway is being followed. Okay, now this should include, okay, the risk of uterine rupture. Okay, so what should the senior obstetrician do in the counseling? The counseling include the risk of uterine rupture. Okay, the obstetrician should tell that we have risks. We have risks like uterine rupture. We have risks like maternal morbidity and individual likelihood of successful VBAC, for example, given the history of prior vaginal delivery. Now, labor should be conducted in a center with a suitable expertise and recourse to immediate surgical delivery. Okay, now we have a questions like a primary gravid in her 5th pregnancy has had a previous lower segment cesarean section for breech presentation. She also had 2 normal deliveries in between the babies, weighing 3.5 kg approximately. She is adamant for vaginal delivery. So what would you offer to her? Okay, so she had previous 2 deliveries, and now she wants VBAC. She's adamant for vaginal delivery. Can we offer vaginal delivery to this woman with such a history of 2 lower segment cesarean section? So, and she is in her 5th pregnancy as well. That is also a very important point, noteworthy point, because whenever she is in her 5th pregnancy, she has 2 lower segment cesarean section. It means she had some vaginal deliveries as well. So in that case, the chances of success are a little bit more as compared to those who never had vaginal delivery. So after checking all the answer, I would like you to pause the video, think about it, and then reply. But to me, the answer of F is the most appropriate. That is, VBAC can be considered after consultant assessment. Okay, so that is the answer. Now we have certain important figures after 2 cesarean sections. We have success rate of 71.1%, uterine rupture of 1.36% after 2 cesarean sections. So remember this point. Hysterectomy 56 per 10,000 compared to 19 per 1,000 in case of previous 1 cesarean section. Blood transfusion risk is 2% compared to 1.2% in case of the previous 1 cesarean section. Okay, now we have a list of percentage risk of uterine rupture. Okay, like elective repeat cesarean section, the percentage risk is less than 0.02%, means 2 per 10,000. In primary gravida, 0.02%, 2 per 10,000, the same risk. Plan VBAC 0.5%, that is 1 by 200. In a previous 2 cesarean section, the risk is 0.9 to 1.8%. Previous classical scar, the risk is 2.4%. Previous uterine rupture, risk is 5%. Now, risk of perinatal mortality with rupture uterus, that is also a very important point. A review of clinical literature found that 5% of symptomatic uterine ruptures were associated with perinatal mortality. Okay, references talk article about uterine rupture. Now, what factors increase the risk of uterine rupture? Okay, those factors include short interpregnancy interval of less than 12 months, post-date pregnancy, maternal age of 40 years or more, obesity, lower pre-labor Bishop score, macrosomia, and decreased ultrasonographic lower segment myometrial thickness. Now, is there any role of myometrial thickness? Okay, myometrial thickness overlying the amniotic fluid, amniotic cavity at the level of uterine scar, having the cutoff of 2.1 to 4 mm, provided a strong negative predictive value for the occurrence of uterine defects. Okay, during VBAC. Means if it is higher thickness of 2.1 to 4, then there is least chance of uterine rupture. Okay, but if we have myometrial thickness of 0.6 to 2 mm, that provide a strong positive predictive value for the occurrence of uterine defect. Okay, now what are the overall aims of antenatal counseling? Okay, what we should do in the antenatal counseling. Okay, the overall aim is that we need to provide the good care to the patient with the previous cesarean section, and everything should be documented in the notes. And also the final decision for the mode of birth should be agreed upon by the woman and the members of maternity team before expected or planned date of delivery. Okay, now another important thing is about VBAC checklist. When a date for elective repeat cesarean section is being arranged, a plan for the event of labor starting before the scheduled date should be documented in the notes. Okay, so we need to do proper documentation in the notes. Okay, and the routine use of VBAC checklist during antenatal counseling should be considered, as they would ensure informed consent and shared decision making in women undergoing VBAC. 10% of women plan for elective repeat C-section go into labor before 39 weeks of gestation, and there is 1 in 4 chance of acquiring emergency cesarean section during VBAC. Okay, now let's come to the likelihood of VBAC success. The success after previous IUL, BMI of 30 is that of the 40%. Okay, so success rate after previous labor dystocia is 40%. Remember this point. And success rate after previous one cesarean section is 70 to 75%. Success rate after previous fetal distress is 73%. Fetal, if we have fetal malpresentation previously, success rate is 84%. Okay, and also if the patient had previous vaginal birth, then the success rate is 85 to 90%. Okay, now another question. 26-year-old woman attend antenatal clinic at 28 weeks of gestation. She had previous one pregnancy 2 years ago, which ended in cesarean section after failure to progress beyond 6 centimeters cervical dilatation, and her current BMI is 30 kg per meter square, and she would like to know the likelihood of successful vaginal delivery should she try for this time, and what is the likelihood of achieving a vaginal birth after cesarean section. Okay, so this patient had previous one pregnancy, and for that she tried the normal vaginal delivery, but there was labor dystocia or no progress beyond 6 centimeter dilatation. For that she had cesarean section. So here we are having the labor dystocia. So what are the chances of success of vaginal birth after labor dystocia? That is about 40%. Now, what factors are associated with the success of VBAC? Okay, success of VBAC are associated with these factors. First of all, greater maternal height. Okay, maternal age of less than 40 years, BMI less than 30, gestation age less than 40, infant birth weight of less than 4 kg or similar, lower birth weight than the index cesarean delivery. Okay, what delivery setting is appropriate for conducting the planned VBAC? So for that, I would like to say that the place we are undergoing the planned VBAC should be equipped with the continuous intrapartum care and monitoring. Okay, and along with that, there should be the senior obstetricians available, and experienced obstetrician should be there to determine the feasibility of VBAC. What is the role of epidural analgesia? Epidural analgesia is not contraindicated in planned VBAC, although increasing requirement for pain relief in labor should raise the awareness of the possibility of an impending uterine rupture. And women should be advised to have continuous electronic monitoring for the duration of planned VBAC. Now, how should women be advised in relation to induction or augmentation of the labor? A woman should be informed that there is 2 to 3-fold increased risk of uterine rupture and around 1.5-fold increased risk of cesarean delivery in case of induced or augmented labor. A senior obstetrician should do discussion with respect to different parameters to the woman, like about the induction of the labor, use of oxytocin. And another thing is that in case when we need the induction of the labor, rather than using oxytocin, if we use amniotomy or Foley catheter, that are associated with a low risk of this core rupture. Now, what elements are involved in the perioperative, intraoperative, and postoperative care for elective repeat C-section? Okay, so about this, I would like to say that if the woman with the previous cesarean section wants cesarean section again, then delivery should be planned at 39 weeks of gestation. And if she wants VBAC, then we can wait up to 41 to 42 weeks of gestation. Okay, and another thing which is important regarding the intraoperative management is that we should do the early recognition of the placenta previa. Okay, placenta previa should be recognized as early as possible by adopting the MDT and informed consents are important consideration. Okay, and also we should consider the antibiotic prophylaxis like ciprofloxacin and metronidazole, and all the women undergoing elective repeat C-section should receive thromboprophylaxis in accordance to the existing RCOG guideline. Now another question, how should women in special circumstances be cared for? We have women with the different obstetric conditions like previous pregnancies complicated by postnate, twin gestation, fetal macrosomia, antepartum stillbirth, or maternal age of 40 years or more. So we should exercise consciousness while approaching to these patients, and those women who are preterm and considering the option for birth after previous delivery should be informed that the planned preterm birth has similar success rate to the planned term VBAC but lower risk of uterine rupture. In VBAC, the blood transfusion of 170 by 10,000 is required in elective repeat C-section, 100 by 10,000. Endometritis 289 per 10,000 in VBAC, 180 per 10,000 in elective repeat C-section. Hysterectomy 23 per 10,000 in VBAC, 30 per 10,000 in elective repeat C-section. Thromboembolic diseases 4 per 10,000 in VBAC, 6 per 10,000 in elective repeat C-sections. Maternal death 17 per 100,000 in VBAC, and elective repeat C-section 44 per 100,000. Okay, now what are the risk of respiratory morbidity at different gestation? Okay, that's very important point, that at 37 weeks of gestation the risk of respiratory morbidity is about 11.4%, at 38 weeks 6.2%, at 39 weeks 1.5%. so you can see that with increasing gestation the risk of respiratory morbidity decreases. Okay, now what are the clinical features associated with uterine rupture? Okay, we have certain cardinal signs of imminent rupture. Those are worsening CTG changes, okay, like prolonged and variable deceleration in 66 to 76% of the cases, hematuria, secondary arrest, small amount of vaginal bleeding, pain over the scar which persists between the contraction. And what are the signs of uterine rupture? Those are fetal bradycardia, upward displacement of presenting part, sudden loss of the contraction, maternal hypotension, heavy vaginal bleeding, abdominal or shoulder pain. Okay, now we have another conditions about the VBAC and elective repeat C-section. Uterine rupture risk in VBAC is 0.5%, and elective repeat C-section uterine rupture is less than 0.02%. Blood transfusion risk VBAC 2%, 1% elective repeat C-section. 4 per 100,000 maternal mortality in VBAC, and 13 per 100,000 in elective repeat C-section. ORC risk if VBAC is done is 5%. ORC risk if VBAC plus instrumental delivery is done, that is 39%. Okay, and respiratory morbidity risk is 2 to 3% in VBAC and 4 to 6% in elective repeat C-section, and stillbirth 10 per 10,000 in VBAC, and this is not applicable. No research data is available about stillbirth rate in elective repeat C-section. HIV risk in VBAC is 8 per 10,000, and that is less than 1 per 10,000 in elective repeat C-section. Okay, now this chart is also very important, that with the previous one cesarean section we have a risk of placenta previa of about 1%, with the previous 2 cesarean section 1.7%, with the previous 3 cesarean section we have risk of placenta previa of 2.8%. Placenta accreta risk with previous 1 cesarean section is 11 to 14%, with the previous 2 cesarean section is 23 to 40%, and it is 67% in case of the previous 3 cesarean section. Accreta risk, okay, is 3, 11, 40, 61, 67% in those women with the first, second, third, and fourth and fifth cesarean sections. Okay, now the risk of placenta previa in the first pregnancy is 1 in 400, with the previous 1 cesarean section, 1 in 160 with the previous 2 cesarean section, and the previous 3 cesarean section is 130, and previous 4 cesarean section it is 1 in 10. Odd ratio for placenta previa with the previous 1 cesarean section 2.2, and 4.1 with the previous 2 cesarean section, and 3 with the previous 22.4 with the previous 3 cesarean. Risk of placenta accreta with previous 1 cesarean section is 3%, with 2 11%, with 3 40%, with 4 61%, with the 5 or more 67. So with the previous placenta previa, if presents again, then there is about 9.7 odd ratio of being of having placenta previa again. Okay, so there is high risk, high chance of having placenta previa again with a previous history of placenta previa. And with the previous cesarean section, this relative ratio, this odd ratio, these are different. So previous with the previous cesarean section, the relative risk is 2.6. With the previous one, 2.2 odd ratio, 4.1 odd ratio with the previous 2, and 22.4% odd ratio with the previous 3 cesarean section. Okay, thank you so much. That was a little. Bismillahirrahmanirrahim.